Welcome back to the deep dive. Get ready to dive deep into a topic that is not only incredibly common in healthcare, but also holds, well, some really fascinating clinical nuances. We're cracking open a stack of source materials today centered around gastrointestinal bleeding, and we're also taking our first look at jaundice. Our mission today, really guided by these materials, they look like excerpts from a pretty comprehensive medical text, is to go beyond just, defining terms. We're here to extract the critical insights, understand the underlying mechanisms, and really grapple with the clinical approach so that you can master this information at, well, a truly professional level.
That's absolutely right. We've got some really in-depth material here from Chapter 48 covering gastrointestinal bleeding. It outlines everything from how it presents to its causes, management strategies, the works. And then we'll touch on a key excerpt from Chapter 49, which introduces jaundice, a sign that, often intertwines with GI health issues. This is all about getting to that core knowledge.
Okay, let's unpack this source material then and start building that deep understanding. So the text wastes no time, does it? Jumps right into defining gastrointestinal bleeding, or GIB, and it immediately frames it based on how it shows up clinically. Overt, or occult. What does the source tell us about overt bleeding, the kind you can actually see?
Yeah, overt bleeding is just what it sounds like. It's visible. The source describes these sort of telltale signs, and they're really critical for that initial recognition and figuring out where it might be coming from. First up, there's hematemesis. That means vomiting blood.
Okay.
It could be bright red, which tells you it's pretty fresh bleeding, or it could be that darker kind of granular material that looks like coffee grounds.
Coffee grounds. Why that look?
Well, that coffee ground texture is a key insight from the source. It happens when blood has been sitting in the stomach for a bit and gets exposed to stomach acid. The acid partially digests the hemoglobin, changing its appearance. It tells you definitively the bleeding is happening somewhere above the ligament of Treitz, so, esophagus, stomach, or upper GI tract.
Got it. So location clue number 1, what's next?
Next is melena. This is described as black, tarry, sticky stool. Really distinct.
Terry. Okay.
And the source gives us a crucial time frame here. This appearance develops because the blood has been in the GI tract long enough, the text says, at least 14 hours, maybe even up to 3 to 5 days.
Wow, that long.
Yeah, long enough for bacteria and digestive enzymes, mainly in the colon, to break down the hemoglobin. And because it needs that transit time, melena usually points to a source higher up, most often upper GI tract, sometimes the small intestine. Somewhere, the blood has a long journey before it exits.
Okay, so hematemesis, melena. What's the third overt sign?
Finally, there's hematochezia. This is the passage of red or maroon blood from the rectum.
Red blood from the rectum, so lower down.
Usually, yes.
Yeah.
It generally suggests the bleeding source is in the lower GI tract, specifically the colon. However, and this is a really important caveat, the text stresses a very rapid, high-volume bleed from the upper GI tract can sometimes move through the intestines so quickly
that it doesn't have time to turn black.
Exactly. There isn't enough time for the blood to be digested. So in that scenario, a brisk UGB can actually present as hematochezia. So while it usually means lower GI, if you see hematochezia plus signs of significant blood loss, like low blood pressure or a really fast heart rate, you have to suspect a severe upper GI bleed.
That distinction is crucial. So the appearance tells you a lot, but you've got to layer in the clinical context, especially how stable the patient is. Okay, so that's overt, the visible stuff. What about occult bleeding, the hidden kind?
Precisely. Occult GIB is chronic, low-grade bleeding that you just don't see. No hematemesis, no melena, no hematochezia. Instead, the source says it usually presents through the systemic effects of that chronic blood loss or the anemia that results from it.
Okay, like what kind of effects?
Think about symptoms related to the body not getting enough oxygen because of low red blood cells. Things like lightheadedness, dizziness, syncope, which is fainting, angina, so chest pain, especially with exertion if someone already had heart issues, or dyspnea, which is shortness of breath.
And the source points to one key finding.
Yes, the key clinical finding with chronic occult GIB, according to the source, is iron deficiency anemia.
Makes sense. Losing blood means losing iron.
Exactly. Because you're losing small amounts of blood consistently, you're losing the iron contained in that blood. And iron is absolutely vital for making hemoglobin. Over time, the body's iron stores just get depleted. This leads to smaller, paler red blood cells.
How does that show up on tests?
On a standard blood test, it shows up as low hemoglobin, obviously, but also a low mean corpuscular volume, or MCV, meaning the average red cell size is small. And typically you see an increased red blood cell distribution width, RDW, which indicates the red cells are varied in size, another sign of iron deficiency.
And how is this often picked up if the person doesn't have symptoms?
Often, yeah. Occult GIB is first detected during routine colorectal cancer screening. A fecal occult blood test, FOBT, or maybe a fecal immunochemical test, FIT, comes back positive.
Ah, so it finds microscopic blood.
Exactly.
Yeah.
Tiny amounts of blood in the stool that aren't visible. That's frequently how it comes to clinical attention in people who feel perfectly fine otherwise.
So understanding how it manifests is step one. Then the source pushes us right away to classify it by location, doesn't it? Which seems fundamental for the workup.
Absolutely fundamental. Pinpointing the source is the big diagnostic challenge. The source defines the key locations pretty clearly. Upper GIB, that's esophagus, stomach, or duodenum. These are the most common sites overall for GIB.
Okay.
Lower GIB, that means the colon.
Got it.
Small intestinal GIB, this is that middle section, right? Jejunum and ileum, between the duodenum and the colon. This area is historically trickier to see and often where that obscure bleeding comes from.
And obscure GIB. The source mentions that term's definition has changed.
Yeah, it has. The source clarifies that obscure GIB used to be the term when you couldn't find a source after doing the standard initial scopes, an upper endoscopy, and a colonoscopy. But as we'll get into, technology has improved, so we approach that category a bit differently now.
Okay, so all this detail on presentation and location. Why is it so important, not just for doctors, but for you listening? The source really emphasizes the significance of GB, doesn't it?
It really does. And the statistics in the source are, well, pretty striking. GB is not some rare thing. It's cited as the most common gastrointestinal condition that leads to hospitalization in the United States. We're talking massive numbers. The source mentions approximately 513,000 hospital admissions each year.
500,000 admissions.
Yeah. And that contributes to an estimated $5 billion in direct healthcare costs annually. It just highlights its major public health and economic impact.
Wow, that definitely puts its importance into perspective. And the source gives a fatality rate, but adds some really crucial context about why patients might die, right?
It does. It notes a case fatality rate around 2% for hospitalized GB patients in the U.S.
Right.
But here's the critical insight. Patients generally die from decompensation of their other underlying medical conditions, not usually from the bleeding itself unless it's truly catastrophic.
Ah, okay, so the bleed pushes them over the edge because of other problems.
Exactly. Think about it. Patients with severe GIB often have other serious issues. Advanced liver disease, maybe heart failure, kidney disease, significant comorbidities, the stress of the bleeding event itself, the loss of blood volume, the procedures needed. It can all overwhelm these already compromised organ systems.
So it's not just about stopping the bleed.
Not at all.
Huh.
While stopping the bleeding is absolutely paramount, successful management requires really comprehensive care of the patient's overall health status. It's not just fixing the leak, it's managing the whole patient.
That's a much richer picture. It's managing a complex patient through a life-threatening event. Okay, let's follow the sources structure then and dive deep into the most common category. Sources of upper GI bleeding, UGIB. The text points to the number one culprit.
That would be peptic ulcers, no question. The source states pretty definitively that peptic ulcers, those breaks in the lining of the stomach or the duodenum, account for about 50% of all UGI hospitalizations.
50%. So 1 out of every 2 patients admitted for UGIB has a bleeding ulcer.
That's the statistic, yeah. Huge proportion.
And the text immediately brings in the importance of what the ulcer actually looks like during the endoscopy, referencing a figure 48:1. It says the appearance gives vital clues.
Yes, absolutely vital clues about prognosis and management. This is a fundamental principle in managing bleeding ulcers, straight from the source material. The endoscopic findings literally guide the immediate treatment and predict the likelihood of that ulcer bleeding again. The source identifies specific high-risk stigmata. These are features seen during the scope that mean there's a high chance the ulcer will rebleed if you don't treat it endoscopically right then and there.
High-risk stigmata. Okay, like what? What are these signs?
At first, there's active bleeding.
Yeah.
You literally see blood spurting or maybe just oozing from the ulcer base.
Yeah.
Pretty obvious sign of high risk.
Right, makes sense.
Second is a non-bleeding visible vessel. This means you can see a little blood vessel, often looks like a little red spot or bump in the base of the ulcer. It isn't actively bleeding at that moment, but its presence tells you a significant vessel has been eroded and could easily open up again.
Like a little warning sign.
Exactly. And the third high-risk sign is an adherent clot. This is a blood clot that's firmly stuck onto the ulcer base. While it might have plugged the hole temporarily, there's a significant risk it could dislodge and lead to rebleeding.
Okay. Active bleeding, visible vessel, adherent clot. Those are the big three. And the source gives numbers on how common these are.
Yeah, it notes that about 20% of patients who present with bleeding ulcers will have one of these high-risk findings on their endoscopy.
1 in 5. And here's the kicker, right? The source says that a third of those patients, the ones with those high-risk signs, will experience further bleeding if they're treated conservatively. Meaning, if you just give them medicine like acid suppression, but don't do any direct endoscopic therapy on the ulcer site itself, a third rebleed rate. That's really high. That explains why intervention is needed.
It's the driving force, yeah. That high rebleeding rate mandates a more aggressive approach for those specific findings.
So what does the text say helps these high-risk patients? What are the endoscopic therapies?
Right, so endoscopic hemostatic therapy is applying treatment directly to that bleeding site through the endoscope. The source lists several techniques that are proven effective, and they're often used in combination. There's bipolar electrocoagulation using electrical energy delivered through a probe to basically heat and seal the vessel shut.
Okay, cauterizing it.
Essentially, yes. Similar idea with a heater probe uses a heated probe tip to compress and coagulate the tissue in the vessel. Then there's injection therapy. You inject substances into or around the bleeding site. The source specifically mentions dilute epinephrine, like a $1,000 to $10,000 solution, or absolute alcohol.
How do those work?
Epinephrine causes blood vessels to constrict, temporarily reducing blood flow, and it also causes some tissue swelling that can help compress the vessel. Alcohol works differently. It actually causes tissue injury and thrombosis, basically scarring the vessel closed. And finally, clips. These are little mechanical devices like tiny metal clamps that are deployed through the scope to grasp the bleeding vessel or pull the edges of the ulcer together over the vessel.
So several tools in the toolbox, and the source emphasizes the benefits.
Big time. It explicitly states that applying these therapies to those high-risk findings leads to significant reductions in further bleeding, shorter hospital stays, lower mortality rates, and reduced overall healthcare costs. It's a clear win-win. Better outcomes for the patient, more efficient use of resources.
Okay, that's high risk. What about the other end of the spectrum, the lower risk ulcers?
Right, so in contrast, the source describes ulcers with lower risk stigmata. These would be things like just a flat, pigmented spot in the ulcer base, maybe some old blood, or the lowest risk of all, a clean base. A clean base means you look at the ulcer crater and see no active bleeding, no visible vessel, no clot, just clean tissue.
And the risk there?
The source is very specific and actually quite reassuring here. Patients with clean-based ulcers have rates of serious recurrent bleeding that approach 0.
0. That's a dramatic difference. So the visual assessment during endoscopy is incredibly powerful for risk stratification.
Absolutely. It truly dictates the immediate risk and consequently the management.
And based on that figure 48 to 1, this translates directly into what happens next.
It does. For stable patients who are found to have a clean-based ulcer on their endoscopy, if they don't have any other medical reasons keeping them in the hospital, they can often be discharged home right after the procedure.
Wow, that really underscores how impactful that simple endoscopic finding is.
Definitely. It helps sort patients out very effectively. Okay, so after the endoscopic therapy for the high-risk folks, what about the medical therapy? The source details high-dose, constant infusion, IV proton pump inhibitor, PPI therapy. Can you unpack that regimen and the thinking behind it?
Sure. The source recommends a specific regimen,
An 80-milligram bolus, a big upfront dose of an IV PPI, followed by a continuous infusion running at 8 milligrams per hour, typically for about 3 days or 72 hours. The rationale is explained directly in the text. The goal is to maintain the intragastric pH, the acidity level inside the stomach, consistently above 6.
Why pH 6? What's magical about that number?
Well, as the source tells us, a higher pH, meaning less acidity, is crucial for stabilizing the blood clot that forms at the bleeding site after endoscopic therapy. Stomach acid and also pepsin, which is a digestive enzyme activated by acid, can actually break down clots and promote rebleeding. So by keeping the stomach environment less acidic, pH 6, you protect that clot, allow it to strengthen, and promote healing of the underlying ulcer, decreasing the chance of it bleeding again.
But the source also mentions something about intermittent PPIs maybe being okay too, not just the continuous infusion.
Yes, exactly. This reflects updated evidence that's been incorporated into the text. The source cites a meta-analysis, a study combining results from multiple trials, which found that high-dose intermittent IV PPI therapy,
Like big doses given every few hours.
yeah, for example, large boluses given maybe every 8 or 12 hours. This meta-analysis found that intermittent dosing is non-inferior to the constant infusion.
Non-inferior meaning.
Meaning studies showed they were basically equally effective in preventing rebleeding and improving other clinical outcomes. So while the constant infusion is the sort of classic approach described, the source presents intermittent dosing as a valid, evidence-based alternative. And crucially, for those lower-risk ulcers we talked about, the flat spot or the clean base, the source says standard doses of oral PPI are sufficient. No need for the high-dose IV therapy in those low-risk patients.
That makes sense. Tailor the intensity to the risk. Now, beyond just stopping the initial bleed, the source addresses the really important problem of preventing recurrence. It notes that if nothing specific is done, rebleeding can happen in a significant chunk of patients, 10 to 50% within a year. What are the main preventative strategies outlined?
Prevention, according to the source, really focuses on tackling the root causes of peptic ulcers. And the three main culprits identified are Helicobacter pylori infection, the use of NSAIDs, and stomach acid itself. So first, H. pylori. If this bacterium is found in a patient who's had a bleeding ulcer, the source is emphatic. Eradicating it with a course of antibiotics dramatically reduces the rebleeding rate. It drops it down to less than 5%. This is one of the most impactful interventions we have in ulcer management.
Huge difference. Okay, what about NSAIDs? We know they're a major cause of ulcers and erosions.
Yes, absolutely. So if a bleeding ulcer occurs in someone taking NSAIDs, that's non-steroidal anti-inflammatory drugs like ibuprofen or naproxen,
Right.
The source's primary recommendation is straightforward. Discontinue the NSAI if at all possible.
But sometimes people need them, right, for arthritis or heart conditions?
Exactly. The source recognizes that reality. Some patients simply must continue NSAIDs for other critical health reasons, so it offers guidance for that scenario. If NSAIDs have to be continued, the recommended strategy based on a randomized trial cited in the source is twofold. First, switch to a cyclooxygenase 2, or KOX2, selective NSAI if possible, as these are generally less damaging to the stomach lining. And second, combine that KOX2 selective NSAID with ongoing daily PPI therapy. That combination provides significant protection against recurrent bleeding.
Okay, COX2 plus the PPI if they must continue. And the third factor was acid.
Right. Acid is managed with ongoing PPI therapy, as we just discussed. This is particularly important for those who had high-risk ulcers initially, and also for patients whose ulcers weren't caused by H. pylori or NSAIDs, the so-called idiopathic ulcers.
Now, there's a very specific point in the text about aspirin use after a bleeding ulcer. This comes up all the time clinically. What does the source say about restarting aspirin?
Yes, this is a really critical nuance and a fantastic example of evidence-based guidance presented in the source. It hinges on why the patient was taking aspirin in the first place. For patients who are taking low-dose aspirin for secondary prevention of cardiovascular events, meaning they've already had a heart attack or stroke, and are taking aspirin to prevent a second one.
Okay, high cardiovascular risk patients.
Exactly. For these patients, the source states aspirin should be restarted as soon as possible after their bleeding ulcer episode has been managed endoscopically and they're stabilized, ideally within 1 to 7 days.
That's soon. Isn't that risky for rebleeding?
It seems counterintuitive, but the source backs this up with a randomized trial. That trial showed a significantly lower 8-week mortality rate, only 1%, versus 13% when was promptly restarted compared to withholding it long-term. The reasoning is that, in this high-risk cardiovascular population, the immediate danger of having another heart attack or stroke from stopping the aspirin actually outweighs the risk of the ulcer rebleeding, provided the ulcer was appropriately treated endoscopically and the patient is on high-dose PPI therapy.
Wow, that's a powerful finding. But the recommendation is different if they were taking aspirin for primary prevention.
Correct. The source makes a clear distinction. If a patient was taking aspirin for primary prevention, meaning to prevent a first cardiovascular event, perhaps based on risk factors alone, and then develops EGB from an ulcer, the source states aspirin probably should be discontinued in most of those cases.
Why the difference?
Here, the risk-benefit calculation shifts. The potential benefit of preventing a first cardiovascular event is generally considered lower than the benefit of preventing a second one. So, in this primary prevention scenario, the risk of the ulcer bleeding again after the initial episode is deemed to outweigh the potential cardiovascular benefit of continuing aspirin, based only on the evidence presented in the source for this specific situation. It really highlights how treatment decisions must be individualized.
Absolutely. And finally, for those bleeding ulcers that aren't caused by H. pylori or NSAIDs, the idiopathic ones.
For those patients where the underlying cause might be unclear or related to other factors, the source recommends indefinite long-term PPI therapy.
Indefinitely.
Yes. It cites a study showing a really high rebleeding incidence, 42% over 7 years, if protective PPI therapy isn't continued in these patients. It emphasizes that the underlying tendency for ulcer formation or bleeding seems to persist, requiring ongoing acid suppression to prevent recurrence.
Okay, that covers peptic ulcers really thoroughly. Moving beyond those, the text covers other sources of UGB. Let's look at Mallory-Weiss tears.
Right, Mallory-Weiss tears. These account for a smaller, though still notable, slice of UGB hospitalizations. The source says around 2 to 10%. The classic clinical picture described is highly characteristic, often letting you suspect it even before the scope. Typically, there's a history of vomiting, retching, or maybe vigorous coughing that happens right before the person starts vomiting blood. Hematemesis.
The vomiting comes first, then the blood.
Exactly. That sequence is key. It's often seen in patients who've had severe nausea for some reason, maybe bulimia, or very commonly in those who've consumed excessive alcohol, leading to forceful vomiting.
And where are these tears usually located?
The source says they're linear tears, usually found right on the gastric side of the gastroesophageal junction, so just below where the esophagus meets the stomach.
And the prognosis, good or bad?
Generally good, according to the source. Bleeding from these tears stops spontaneously in a very high percentage of patients, something like 80 to 90%. And recurrent bleeding is uncommon, only occurring in maybe 0 to 10%. Because they so often stop on their own, endoscopic therapy, like clips or cautery, is usually only indicated for the minority of cases where the tear is seen to be actively bleeding during the endoscopy and doesn't seem to be stopping.
Okay, makes sense. Let's move on to varices. The source mentions these have a wider range of incidence depending on the population and are linked to poorer outcomes.
Yes, esophageal varices. These are basically dilated, swollen veins in the lining of the lower esophagus. They're almost always a direct consequence of portal hypertension, high pressure in the portal vein system, which is usually caused by advanced liver disease, most commonly cirrhosis. Their contribution to UGB hospitalizations varies a lot. The source says 2 to 40%, because it depends heavily on the specific patient population being studied, like how many patients with severe liver disease are included.
And why the poorer outcomes?
Patients bleeding from esophageal varices do tend to have worse outcomes compared to those bleeding from, say, ulcers. Primarily because their underlying liver disease makes them much more fragile. They're less able to tolerate significant blood loss, prone to complications like infection or worsening liver function, and the bleeding itself can be very difficult to control.
So how does the source say acute variceal bleeding is treated?
The standard approach, according to the source, involves a combination of both endoscopic therapy and medical therapy, started immediately. Endoscopic ligation, or banding, is the preferred endoscopic technique. This involves placing small rubber bands around the varices through the endoscope, which strangulates them and stops the bleeding.
Okay, banding. And the medical therapy.
Medical therapy involves giving IV vasoactive medications for about 2 to 5 days. The source lists common examples: octreotide, somatostatin, vaporeotide, or tolopressin, though tolopressin availability varies. These drugs work by constricting blood vessels in the splanchnic circulation, the gut circulation, which helps reduce blood flow and pressure in the portal vein system, and therefore reduces pressure within the varices themselves. And the source is really explicit here. Combining endoscopic ligation with vasoactive medication is superior to using either approach alone when it comes to decreasing rebleeding during that critical acute episode.
Got it. Combination therapy is key acutely. What about preventing future variceal bleeds long-term?
For long-term prevention, after the acute bleed is controlled, the source recommends another dual approach, a combination of non-selective beta blockers.
Like propranolol or nadolol?
Exactly. Those are the common ones. They work by lowering portal pressure over the long term. That's combined with ongoing repeated sessions of endoscopic ligation, basically banding any remaining varices until they're eradicated. The source states this combination of beta blockers plus serial ligation is more effective than using either therapy by itself in reducing the risk of future esophageal variceal bleeding episodes.
The text also discusses the role of TPS in managing variceal bleeding. What's that?
Yes, TPS. That stands for transjugular intrahepatic portosystemic shunt. It's a procedure, usually done by interventional radiologists, where they create a direct channel or shunt within the liver. This channel connects the high-pressure portal vein directly to a lower-pressure hepatic vein, which drains blood out of the liver.
So it bypasses the congested liver?
Essentially, yes. It diverts a significant amount of blood flow away from the portal system, thereby lowering the pressure in the portal vein and consequently in the esophageal varices, reducing the risk of bleeding.
When is TIP-PS used, according to the source?
The source says TIP-PS should definitely be considered for variceal bleeding that keeps recurring despite optimal endoscopic and medical management kind of a rescue therapy. However, a really key and somewhat evolving insight highlighted in the text is that TIP-PS should also be considered early. Specifically, within the first 1 to 2 days of hospitalization for patients who present with acute variceal bleeding and have advanced liver disease.
Which patients specifically?
The source specifies patients with Child-Pugh Class B liver disease or those with high-risk Child-Pugh Class C disease, defined by a score of 10 to 13. It cites randomized trials showing that this strategy of placing a TIP-PS early in these specific high-risk cirrhotic patients significantly decreases both rebleeding rates and mortality compared to sticking with standard therapy alone.
That's a big deal, improving mortality.
It really is. It's a prime example of how tailoring aggressive interventions based on the severity of the underlying illness can dramatically improve outcomes.
And it seems portal hypertension doesn't just cause esophageal varices, it can cause bleeding elsewhere too.
It absolutely can. That elevated pressure backs up throughout the gut's venous system. The source specifically mentions gastric varices, dilated veins in the stomach, which can be particularly tricky to treat endoscopically. Varices occurring in the small intestine or the large intestine, less common than esophageal or gastric, but they happen. And also a condition called portal hypertensive gastropathy or enterocolopathy. This isn't varices, but rather changes in the actual lining of the stomach, small intestine, or colon, caused by the chronic congestion from high portal pressure, making the lining fragile and prone to oozing blood.
How are bleeding gastric varices treated? The source mentions something specific.
Yes, for bleeding gastric varices, the preferred endoscopic treatment mentioned, if it's available, is endoscopic injection of a tissue adhesive, like N-butyl cyanoacrylate. It's essentially a medical-grade superglue injected into the varix to seal it off.
Gluing it shut.
Basically, yes. If that's not an option, or if it fails, the source says TPS is the recommended next step. Again, showing how the specific location and type of bleeding dictates the therapy.
Okay, next up in the source material is erosive disease. And the text seems careful to differentiate this from ulcers.
Yes, and this is a really crucial distinction, mainly because it relates to the severity of bleeding you'd expect. The source defines erosions as superficial breaks in the lining of the GI tract, esophagus, stomach, duodenum that are strictly confined to the mucosa. That's the very innermost layer. The vital point here is that erosions typically cause only mild UGIP. Why? Because the larger blood vessels, the arteries and veins that can cause really significant hemorrhage, lie deeper in the submucosa beneath the mucosal layer. So simple erosions don't usually reach those big vessels.
Got it. Superficial means less severe bleeding, usually. What causes these erosions?
Erosive gastritis in the stomach and erosive duodenitis in the duodenum account for a decent number of UGIV hospitalizations. The source estimates maybe 10 to 15%. Erosive esophagitis, often due to severe acid reflux or GRD, adds another 1 to 10%. But the source identifies the most important cause of gastric and duodenal erosions as NSAID use. It even notes that up to 50%, half, of chronic NSAID users may have gastric erosions visible if you scope them.
Half. That's a lot.
It is. Other potential causes listed include alcohol consumption, H. pylori infection, though H. pylori is more strongly linked to ulcers, and something called stress-related mucosal injury.
Okay, tell me more about stress-related mucosal injury. The source makes it sound like it only happens in very specific situations.
It is very specific. This term, according to the source, refers to mucosal damage erosions or sometimes even shallow ulcers that occurs only in extremely ill patients. We're talking critically ill people in the ICU. The examples given really illustrate the severity. Patients with serious trauma, those undergoing major surgery, people with extensive burns covering more than a third of their body, patients with major intracranial disease like a severe stroke or head injury, or those with severe medical illnesses requiring intensive care, like being on a mechanical ventilator or having a significant blood clotting disorder, coagulopathy.
So not just everyday stress.
Definitely not. And the source is careful to state that severe, clinically significant bleeding from stress-related injury should really only happen if actual ulceration develops, digging deeper than just the superficial erosions. It also notes that while the mortality rate in these critically ill patients is high, it's primarily due to their profound underlying illnesses, not typically the GI bleeding itself, unless the bleeding is truly massive and uncontrolled.
Has the incidence of bleeding from this type of stress injury changed over time?
Yes. The source notes a significant decrease in clinically significant bleeding from stress-related mucosal injury in recent years.
Why is that?
It attributes this reduction most likely to overall improvements in the care of critically ill patients in ICUs. Better management of their underlying conditions, better resuscitation, maybe better nutritional support. It all likely helps protect the GI tract lining as well. Now, regarding actively preventing this bleeding with medication, what we call prophylaxis in these high-risk ICU patients, the source says pharmacologic prophylaxis has somewhat limited overall benefit, but it may be considered. It references a large recent randomized trial involving over 3,000 ICU patients with risk factors. That trial showed a small but statistically significant benefit from giving PPIs in terms of reducing the rate of clinically important bleeding events compared to placebo.
A small benefit. Okay. And how do PPIs stack up against the older drugs, the H2 blockers, for this purpose?
The source cites meta-analyses comparing PPIs to H2 receptor antagonists like ranitidine or famotidine for stress ulcer prophylaxis. These suggest that PPIs are more effective than H2RAs at reducing both overt GI bleeding and clinically important GI bleeding in these critical care settings.
Okay, PPIs seem better at stopping the bleeding.
They do seem more effective for that specific outcome. However, and this is a really key detail highlighted by the source for clinical practice, those same studies found no differences between PPIs and H2RAs when it came to overall mortality rates or the incidence of nosocomial pneumonia, hospital-acquired pneumonia, which is always a potential concern when you suppress stomach acid.
Interesting. So they prevent more bleeding, but don't seem to change survival or pneumonia rates.
That's what the evidence presented suggests. It kind of raises the implicit question of how clinically significant that reduction in bleeding really is if it doesn't translate into better survival or fewer major complications like pneumonia in these very sick patients.
Point to consider. Finally, for you, Jib, the text rounds things out by listing some less common but still important causes.
Yeah, it's good to be aware of these rarer possibilities when the usual suspects like ulcers, varices, or erosions are ruled out. The source lists quite a few. Neoplasms, that means tumors, benign or malignant, in the esophagus, stomach, or duodenum, can certainly bleed. Vascular ectasias, these are different from varices. They're abnormal, dilated, often fragile blood vessels in the lining. Examples include those seen in hereditary hemorrhagic telangiectasias, which is Osler-Weber-Rendu syndrome, and a condition called gastric antral vascular ectasia, or GAVE. GAVE is sometimes called watermelon stomach because of its characteristic striped appearance on endoscopy.
Watermelon stomach. Okay.
Then there's Dieulafoy's lesion. This one is particularly fascinating, can be tough to diagnose. It's basically an abnormally large artery that runs just beneath the mucosal surface, usually in the stomach. It bleeds from a tiny, almost pinpoint-sized mucosal defect, not a typical ulcer crater. It can cause really massive, often pulsatile bleeding.
Sounds dangerous.
It can be. Also listed is prolapse gastropathy. This happens when the lining of the upper stomach sort of slides up or prolapses into the esophagus, often associated with chronic forceful vomiting or retching, particularly in alcoholics. Aortoenteric fistulas, these are rare but incredibly life-threatening. It's an abnormal connection that forms between the aorta, the body's main artery, and the GI tract, usually the duodenum. It almost always occurs as a late complication after aortic surgery involving a graft.
Yikes.
And lastly, hemophilia, or hemosuccus pancreaticus. These mean bleeding that originates within the bile duct system, biliary, or the pancreatic duct, hemosuccus pancreaticus, and then drains out into the duodenum, presenting as UGEB.
Wow, okay, that is a really comprehensive list of upper GI causes. Let's take a breath and move downstream now into the small intestine and this concept of obscure GEB. The source said the definition has evolved.
That's right. The source explains that how we define obscure GEB has changed quite a bit, largely thanks to advances in diagnostic technology. Previously, that term was used pretty much any time a bleeding source wasn't found after doing the standard workup, which historically meant just an upper endoscopy and a colonoscopy. If both were negative, the bleeding was labeled obscure.
But now we have better ways to look at that whole middle section, the small intestine, that we didn't have before.
Exactly. With the development and now widespread use of things like video capsule endoscopy and specialized deep enteroscopy techniques, the small intestine, which is typically way beyond the reach of standard scopes, is much more accessible for investigation. Because of this, The source estimates that about 75% of bleeding that used to be just called obscure is now actually found to originate somewhere in the small intestine.
So most obscure bleeding isn't truly obscure anymore, it's small intestinal bleeding.
Pretty much, yeah. Overall, the source estimates that bleeding originating solely in the small intestine accounts for maybe about 5% of all GIM cases that present clinically.
Okay, so what are the most common causes of bleeding, specifically in the small intestine, particularly in adults?
The source lists the primary culprits in adults as being vascular ectasias.
Okay.
Again, these abnormal blood vessels, also called angiectasias or AVMs, are a very frequent cause of bleeding throughout the small bowel. They're often multiple and kind of diffuse.
Okay, same culprits as elsewhere sometimes.
Often, yes. Also, neoplasms tumors. Various types can occur in the small bowel, like gastrointestinal stromal tumors, GISTs, carcinoid tumors, adenocarcinomas, less common than in the colon, but they happen, lymphomas, and even metastatic cancer spreading from elsewhere. And third, NSAID-induced erosions and ulcers. Just like in the stomach and duodenum, chronic NSAID use can definitely damage the lining of the small intestine and cause bleeding there too.
And the source mentions a different common cause in kids.
Yes, for children, the source highlights Meckel's diverticulum as the most common cause of significant small intestinal G.
What is that exactly?
It's a congenital thing, a small pouch or outpouching in the wall of the small intestine, usually the ileum, that's left over from fetal development. The problem is, sometimes this pouch contains ectopic tissue that doesn't belong there, like stomach lining or pancreatic tissue.
And that causes bleeding how?
If it contains stomach lining, it can secrete acid, which causes an ulcer in the adjacent normal small bowel lining, leading to bleeding. The source notes that Meckel's becomes a less frequent cause of bleeding as people get older. Other less common causes mentioned for the small intestine include inflammatory conditions like Crohn's disease, various infections, ischemia, lack of blood flow to the bowel, vasculitis, inflammation of blood vessels, small bowel varices, usually from portal hypertension, other types of diverticula, intussusception, where the bowel telescopes into itself, Dieulafoy's lesions, though more common higher-ups, aortoenteric fistulas again, and duplication cysts.
Quite a list. How is small intestinal vascular ectasia typically treated, according to the source, since that seems common?
Right. If these vascular ectasias can be reached endoscopically, which often requires those specialized deep enteroscopy techniques we mentioned.
Like balloon enteroscopy.
Exactly. Double balloon, single balloon, or spiral enteroscopy. If you can reach them, the source says endoscopic therapy is used. Techniques like argon plasma coagulation, APC, which kind of sprays electrical energy to cauterize superficially, are often employed. Based on observational studies, this can be initially effective at stopping bleeding from these lesions. However, the source points out a really significant challenge. Rebleeding from small intestinal vascular ectasias is very common.
Oh, really? So it doesn't always last?
Often not. The source cites a systematic review that reported a high rebleeding rate, 45%, over a mean follow-up of just over 2 years. That means almost half the patients bled again. So while endoscopy can definitely help control acute bleeding, it's often not a permanent fix, and patients might need repeated treatments or other long-term strategies.
What about medical treatments for small intestinal bleeding, particularly from these vascular ectasias? Any pills that help?
The source provides a very clear, evidence-based statement on one therapy that used to be tried sometimes: estrogen-progesterone compounds. The source states these are not recommended.
Why not?
Because a large, multi-center, double-blind, placebo-controlled trial found absolutely no benefit. So evidence clearly showed it didn't work, and practice changed accordingly. The source does mention one drug, thalidomide, which showed a significant benefit in reducing bleeding from small intestinal vascular ectasias in one randomized trial. However, it explicitly states that this finding needs further confirmation from more studies before it can become a standard recommendation. So kind of a maybe but wait and see situation for thalidomide. For other isolated specific lesions found in the small bowel, like tumors, the source generally says surgical resection is required.
Okay, makes sense. Let's shift gears one last time and head down to the colon for lower GI bleeding, or LGI. Before we get into the major causes within the colon, what does the text say are the most common causes of any sort of LGI, including minor stuff that's often assessed first?
Right. The source identifies hemorrhoids as probably the single most common cause of LGIG overall, and anal fissures are also frequent culprits. These cause minor bleeding, often bright red on the toilet paper, and usually pain.
Okay. Hemorrhoids and fissures, very common.
Very common. But importantly, the source notes that these are very localized issues right around the anal canal, and they rarely lead to hospitalization for the bleeding itself. So they're usually things that get evaluated in the office or clinic and often ruled out first before launching into a big workup for more serious causes, especially if the bleeding is minor.
Got it. So if those local issues are excluded or if the bleeding is more significant, what's the most common cause of significant LGI in adults that requires further investigation, according to the source?
The source points clearly to diverticulosis as the most common cause of significant LGI in adults. These are those small pouches or sacs that can form in the wall of the colon, especially if people get older.
Diverticulosis, number one cause. What else is on the list for significant LGI?
Other significant causes listed are vascular ectasias again. These pesky abnormal vessels show up here too. The source specifically notes they're common in the proximal colon, that's the ascending colon, the first part, particularly in older patients, specifically those over 70 years old.
Okay.
Neoplasms, so colon cancer, adenocarcinoma, and also large precancerous polyps are important causes of colonic bleeding, which can be either overt red blood or occult blood loss leading to anemia. Colitis, which just means inflammation of the colon lining. This can have various underlying causes, which the source lists. Ischemic colitis, from reduced blood flow to the colon wall. Infectious colitis, from various bacteria or viruses. Inflammatory bowel diseases like ulcerative colitis or Crohn's disease affecting the colon. And also NSAI-induced colitis or ulcers in the colon.
NSAIDs can hit the colon too.
They can, yes. Not just the upper tract. Also listed is post-polypectomy bleeding. This is bleeding that occurs, sometimes delayed, after a polyp has been removed during a colonoscopy. It's a relatively common procedural complication that presents as LGI. In radiation proctopathy, this is damage and inflammation, often with bleeding, specifically in the rectum caused by prior radiation therapy for pelvic cancers, like prostate or cervical cancer.
And any rarer causes mentioned for the colon?
Yes, the source lists a few others. Solitary rectal ulcer syndrome, a specific condition causing ulceration in the rectum. Varices, most commonly rectal varices, usually due to portal hypertension. Lymphoid nodular hyperplasia. Vasculitis affecting the colon. Trauma and aortocolic fistulas, similar to aortoenteric but involving the colon.
Okay. Let's focus back on diverticular bleeding for a second, since the source says it's the most common major cause. What are its characteristic features? How does it typically present?
The source gives a pretty clear description. Diverticular bleeding typically has an abrupt onset. It's usually painless. That's a key distinguishing feature from something like colitis or fissures. It can sometimes be massive, meaning a large volume of blood is passed quite suddenly, and it often originates from diverticula located in the right side of the colon, even though diverticula are more common on the left. Another key point the source makes for differentiation. Chronic or occult bleeding is not characteristic of diverticular bleeding. It's almost always a sudden, acute event.
Okay, abrupt, painless, sometimes massive, often right-sided. Does it usually stop on its own, or does it keep bleeding?
Good news here, mostly. The source is quite reassuring, citing case series from the U.S. and Europe that suggest bleeding from chronic diverticula stops spontaneously in 90% or even more of patients.
90% stop on their own. That's high.
It is. And rebleeding rates after an initial episode in those regions are reported as relatively low on long-term follow-up, maybe around 15% over 4 or 5 years.
Yeah.
Although the source does make a specific note that rebleeding rates seem to be substantially higher in reports coming out of Asia, suggesting there might be some geographic or population-specific factors influencing the natural history.
Interesting difference. So for the 10% or so where it doesn't stop spontaneously, how is persistent diverticular bleeding managed?
Right. For that minority where the bleeding continues, the source discusses intervention. It says case series suggests that endoscopic therapy may decrease recurrent bleeding.
Like clipping the diverticulum.
Potentially, yes, or maybe applying cautery near the vessel. But the big caveat is that this is only possible if you can actually identify the specific bleeding diverticulum during the colonoscopy, which can be really challenging when there's a lot of blood in the colon obscuring the view.
Yeah.
If the bleeding site from diverticulosis is identified during angiography, that's the test where they inject dye into the arteries, then transcatheter arterial embolization using a super selective technique, meaning plugging up just the tiny artery, feeding that diverticulum is noted to stop the bleeding in a majority of patients.
And if those don't work?
For persistent or refractory diverticular bleeding that just can't be controlled by endoscopic or angiographic means, the source says segmental surgical resection, basically removing the segment of the colon containing the problematic diverticula, is the recommended course. Now, in contrast to that typically abrupt diverticular bleeding, the source notes that bleeding from colonic vascular cases can be different. It might be overt red blood, or it could be chronic occult bleeding. It tends to be more chronic or intermittent and only occasionally becomes hemodynamically significant, meaning it rarely causes those drastic drops in blood pressure acutely, though it certainly can lead to chronic iron deficiency anemia over time.
And how are those colonic vascular ectasias or maybe other discrete bleeding lesions like ulcers or post-polypectomy sites treated?
Similar approaches as used elsewhere. If the lesion is identified and accessible during colonoscopy, endoscopic hemostatic therapy can be used things like thermal therapy, APC, electrocoagulation, or clip application. If endoscopy isn't successful or feasible, or for persistent bleeding, transcatheter arterial embolization might also be attempted for these lesions. And the source's algorithm essentially concludes with surgery as the required step for major persistent or recurrent bleeding from colonic sources that just cannot be controlled by medical, endoscopic, or angiographic methods. There's also that specific kind of intriguing connection noted again in the source. Hague syndrome, that's the combination of bleeding vascular ectasias, often in the colon or small bowel, and aortic stenosis, narrowing of the aortic valve in the heart. It's one of the surprising facts you find in the source notes that patients with this specific syndrome appear to benefit, in terms of their GI bleeding, from undergoing aortic valve replacement surgery. Fixing the heart valve somehow helps stop the bad bleeding.
That really does underscore how interconnected things are in the body. Okay, we have spent a lot of time detailing the sources in all the different locations, upper, small bowel, colon. Now let's piece together how a medical professional actually approaches a patient who walks in or comes into the ER with suspected GIBA. The text outlines this whole process comprehensively, doesn't it? Guiding through assessment, differentiation, evaluation, and management.
It does, yeah. It lays out a systematic approach. And the source starts with the absolute first step when a patient presents. Initial assessment of severity. It states pretty clearly that measuring heart rate and blood pressure is the best way to initially assess the hemodynamic significance, basically. How much blood loss the patient has sustained and how well their body is coping.
Vital signs first.
Vital signs first. Because significant bleeding leads to a predictable pattern. First, you might see postural vital sign changes. The heart rate jumps up or the blood pressure drops when they go from lying down to sitting or standing. As bleeding gets worse, you see tachycardia, fast heart rate, even when they're lying flat. And in really severe decompensated cases, you get recumbent hypotension. Their blood pressure is low, even when they're lying down. Those are signs of major volume loss.
What about checking the hemoglobin level right away? Isn't that the immediate reflex test?
You definitely check it, yes. But the source provides a really critical piece of insight regarding how to interpret that initial hemoglobin level in acute bleeding. It emphasizes that hemoglobin levels often do not fall immediately.
Why not? If you're losing blood.
The explanation is key. When someone bleeds acutely, they lose whole blood. That means they lose both red blood cells and the plasma fluid they're suspended in roughly equal proportions initially. So the concentration of red cells in the blood that's left in the circulation, which is what hemoglobin and hematocrit measure, might be initially unchanged or only minimally decreased, even if they've lost a lot of volume.
Ah, okay. The blood is just as concentrated, there's just less of it overall until the body starts shifting fluids.
Exactly. The body hasn't had time to compensate yet by pulling fluid from tissues into the bloodstream to restore the volume. The source states it can take up to 72 hours for that fluid shift to fully occur. As that extravascular fluid enters the vascular space, it dilutes the remaining red blood cells, and that's when the hemoglobin and hematocrit levels will drop noticeably.
That's vital clinical knowledge, and initially, normal hemoglobin doesn't rule out a big bleed.
Absolutely vital. Especially in an unstable patient, you trust the vital signs more than the initial H&H. Now, regarding blood transfusions, the source gives a specific evidence-based threshold. It recommends transfusing patients when their hemoglobin level drops below 7 GDL.
7? That seems lower than maybe it used to be.
It is, for many situations, and this recommendation is explicitly based on evidence from a large, randomized controlled trial, particularly in acute UG patients. That trial showed that using this more restrictive transfusion strategy, waiting until hemoglobin is below 7, resulted in decreased rates of rebleeding and even death compared to a more liberal strategy, transfusing earlier, maybe when hemoglobin fell below 9 or 10.
So less is more in this case.
In many JABE cases, particularly UJABE, the evidence suggests yes. It's a clear example of how clinical trial results directly influence and change practice guidelines.
But someone with that slow, chronic G we talked about earlier, they might present very differently in terms of their labs, right?
Totally different picture sometimes. The source points out that patients with slow, chronic GI can have dramatically low hemoglobin values like 5 or 6. But because their body has gradually adapted to that low level over weeks or months, their blood pressure and heart rate might be perfectly normal. These are the patients who typically develop that iron deficiency anemia we discussed, with a low MCV and increased RDW on their blood tests, indicating that chronic iron depletion from ongoing, slow blood loss.
Okay. The text also provides specific clues for trying to differentiate between an upper GI bleed and a lower GI bleed based on the patient's presentation, reinforcing points we touched on, but adding more detail on interpretation.
Yeah, interpreting how the bleeding manifests is key for localization. He reiterates, hematemesis vomiting blood, red or coffee grounds is definitive. That is an UG source. No question. Melina, that black terry stool indicates blood has been in the GI tract for a significant time, at least 14 hours, maybe days. The source notes the more proximal or higher up the bleeding source is, the more likely you are to see melina, just because it allows more time for that bacterial digestion in the gut.
Right.
Hematochezia passing red or maroon blood usually points to an LGI source, like the colon. But, and here's that crucial caveat again, the source stresses that a really brisk UGB can also present as hematochezia.
If transit is fast enough.
Exactly. If the blood volume is so large and it moves through the bowel so quickly, it doesn't have time to turn black. The key clinical clue here, the source notes, is that hematochezia resulting from a brisk UGIB is typically accompanied by signs of significant hemodynamic instability, low BP, fast heart rate, and often a rapidly dropping hemoglobin level. Those are signs it's a high-volume bleed coming from somewhere higher up. It also mentions that bleeding from the small bowel can present as either melina or hematochezia, depending on the rate of bleeding and transit time.
Are there other clues mentioned for UGIB besides the type of bleeding?
Yes, a couple of others. Hyperactive bowel sounds on exam. The gut gets stimulated by the blood moving through it, and an elevated blood urea nitrogen, or BUN, level on blood tests.
You mentioned BUN before. Why exactly does that go up with UGIBs?
The source explains the specific mechanism. It's thought to be a combined effect. First, volume depletion from the blood loss can affect kidney function, causing BUN to rise. But second, and maybe more specifically for UGEB, is the digestion and absorption of blood proteins in the small intestine. When you bleed into the upper tract, that blood gets digested like food as it passes through the small bowel. The breakdown products of those absorbed blood proteins include nitrogen, which gets converted to urea in the liver, thus increasing the BUN level in the blood. So it's partly volume status, partly protein load from the digested blood. It's a pretty specific indicator for an upper source.
That's a great physiological insight. The source also comments on using nasogastric tubes, right? Putting a tube down into the stomach to check for blood. What's the verdict on that?
Yeah, nasogastric NG aspiration. The source gives some important caveats about its utility. First, a non-bloody NG aspirate does not reliably rule out an active UGIB. The source says it could be non-bloody in about 15% of patients who actually have a significant UGIB, especially if the bleeding is duodenal and refluxing back into the stomach is limited, or if the bleeding is temporarily stopped.
Okay, so a negative test isn't conclusive.
Not at all. Also, seeing bile in the aspirate doesn't necessarily exclude an UGIB source either. The source notes that reports of bile presence can be incorrect about half the time. And finally, testing an aspirate that isn't grossly bloody for occult blood using those card tests is generally not considered useful. So the bottom line from the source seems to be, if the NG aspirate is bloody or has coffee grounds, that confirms an UGIB. But a negative or non-bloody aspirate is not definitive and shouldn't be relied upon to rule out a significant upper bleed, particularly in unstable patients or those presenting with hematochezia suggestive of a brisk UGIB.
Got it. Helpful if positive, but limited if negative. Okay, let's move into the formal evaluation and management algorithms laid out in the source, starting with UGIB, guided by that figure 48:1.
Right, so after the initial assessment and resuscitation, getting IVs in, maybe giving fluids or blood based on vital signs and that hemoglobin threshold, the next step is formal risk assessment. We need to figure out how likely this patient is to rebleed or have a bad outcome. The source identifies key factors that predict rebleeding and death. Baseline hemodynamic compromise, so were they unstable on arrival, increasing age, and the presence and severity of other medical conditions or comorbidities.
Makes sense. Sicker, older patients do worse?
Generally, yes. And this is where the source introduces objective risk stratification tools to help quantify that risk. It specifically highlights the Glasgow-Blatchford score, which is detailed in a table, table 48:1. This score uses a combination of clinical and simple lab variables. Things like their BUN level, their hemoglobin, systolic blood pressure, pulse rate, whether they presented with melena or syncope, and if they have a history of liver disease or heart failure. The total score can range from 0 to 23.
And how does this score help?
Well, a fascinating insight here, and a really practical one, is how a low score on the Glasgow-Blatchford scale can significantly impact management strategy.
How low are we talking?
The source suggests that patients who score a 0 or a 1 on this scale can potentially be considered for discharge directly from the emergency room with outpatient follow-up arranged.
Really? Sent home. Why?
The evidence cited to support this less intensive approach is quite compelling. Only about 1% of patients who fall into this very low-risk score category, 0 or 1, actually end up requiring a blood transfusion, needing any kind of endoscopic or surgical intervention to stop bleeding or dying from the event. So this score is presented as a clinically validated tool that helps identify a subset of patients who are at such low risk that they likely don't need to be admitted to the hospital, which is obviously a major benefit for both the patient experience and for healthcare resource utilization.
That's incredibly useful. Okay, what about medications given before the patient actually gets their endoscopy? Does the source recommend anything?
It discusses a couple of things. First, giving an IV PPI infusion prior to endoscopy. The source says this can be considered upon presentation. What's the effect? Well, it states that giving a PPI infusion beforehand decreases the likelihood of finding those high-risk stigmata, like active bleeding or visible vessels, on the ulcer when they do the scope. It can also reduce the need for performing endoscopic hemostatic therapy during that initial procedure.
Okay, so it makes the ulcer look less scary on the scope.
Essentially, yes. However, and this is a really critical point derived from the evidence presented in the source, pre-endoscopic PPI therapy does not seem to improve overall major clinical outcomes. It doesn't change the rates of further bleeding, the need for surgery later, or overall mortality.
Huh. That's interesting. It changes the endoscopic findings, but not the patient's outcome.
That's what the data suggests. It highlights a key nuance. Sometimes an intervention can alter intermediate findings without actually changing the things that matter most to the patient, like survival or needing surgery. It makes the role of routine pre-endoscopy PPI a bit debatable based on this evidence.
What about erythromycin before the scope? I think I saw that mentioned.
Yes, erythromycin. The source suggests giving a dose, like 250 milligrams IV, about 30 to 90 minutes before the endoscopy. It's used here not as an antibiotic, but as a promotility agent.
Promotility. To move things along.
Exactly. Erythromycin stimulates contractions in the stomach. The idea is that it helps clear out any blood, clots, or food residue from the stomach before the scope goes down, giving the endoscopist a much better view of the lining. The source says this potentially reduces the need for having to do a repeat endoscopy later if the first view was poor, and it might even shorten the hospital stay by making that initial procedure more definitive and successful in finding and treating the source.
Makes sense. Better view, better outcome for the procedure itself. Any special pre-endoscopy meds for cirrhotic patients?
Yes, very specific recommendations for patients with cirrhosis who present with UG. The source advises giving two things immediately upon presentation, even before the diagnosis is confirmed. First, an antibiotic, like oxycettriaxone. Why? Because cirrhotic patients are highly susceptible to bacterial infections, and infections can actually trigger or worsen variceal bleeding. Studies show that giving prophylactic antibiotics significantly reduces infections, rebleeding, and mortality in this vulnerable group. Second, an IV vasoactive medication, like octreotide. As we discussed for known variceal bleeding, giving this early may help control potential variceal bleeding in those crucial first hours by reducing portal pressure, even before the endoscopy confirms varices are the cause.
So antibiotics and octreotide up front for anyone with cirrhosis and UG. Got it. Now, when should the endoscopy itself actually be performed for patients who are hospitalized with UG? Is there an urgency?
The source provides a clear time frame. Upper endoscopies should generally be performed within 24 hours of presentation or admission in most patients hospitalized with UG.
Within 24 hours. Does that apply to everyone? Low risk and high risk?
Yes, the source suggests this 24-hour window applies regardless of whether the patient has clinical features predicting low risk or high risk based on that initial assessment.
Okay, but is there any benefit to doing it even faster, like rushing them down within, say, 6 hours, especially for those high-risk patients?
That's a really important practical question, and the source addresses it directly based on research. It states that even in patients judged to be high-risk clinically, performing the endoscopy more urgently, specifically defining urgent as within 6 hours of presentation or consultation, does not appear to improve overall clinical outcomes. Things like rebleeding rates, need for surgery, or mortality were not shown to be better with the ultra-early scope compared to doing it within the standard 24 hours.
Another instance where intuition might say faster is better, but the evidence doesn't support it for major outcomes.
Exactly. It seems that stabilizing the patient first, getting the medications on board, and doing a well-prepared, high-quality endoscopy within that 24-hour time frame is the optimal strategy, rather than rushing for speed itself.
So, if faster isn't better for outcomes, why the push to do it within 24 hours at all, especially for those low-risk patients identified by the Glasgow-Blatchford score?
Good question. The primary benefit of early endoscopy within 24 hours in those clinically low-risk patients, the ones who are stable, don't have severe comorbidities, is mainly one of efficiency and appropriate patient disposition.
Right.
Doing the scope early allows you to quickly identify the patients who have truly low-risk endoscopic findings, like the clean-based ulcers, erosions, or non-bleeding Mallory-Weiss tears. Once you confirm those low-risk findings, a significant proportion of these patients, the source suggests 40% or more, can be safely discharged from the hospital much sooner.
So it's about streamlining care and avoiding unnecessary hospital days for the low-risk group.
Precisely. It reduces hospital length of stay and associated costs. So for the low-risk patients, the main benefit of the 24-hour scope is more about efficiency, appropriate resource utilization, and patient flow, rather than a dramatic impact on their clinical prognosis from the timing itself. Of course, for the patients who are found to have high-risk endoscopic findings, like varices or ulcers with active bleeding or a visible vessel, during that endoscopy within 24 hours, they absolutely benefit from receiving targeted hemostatic therapy applied right then and there during the procedure.
Okay, that clarifies the rationale for the 24-hour window. Let's switch gears now to the evaluation and management of lower GI bleeding, LGIB, guided by Figure 48.2 in the source, and also touch on small intestinal and obscure JAGIB evaluation.
Right, so the source starts the LGB algorithm, the pathway for managing suspected lower bleeds, with a really crucial first step, especially for patients presenting with hematochezia, red blood per rectum, and signs of hemodynamic instability, Libby fast pulse. What's the first step for them? They should have an upper endoscopy first.
Upper scope first, even if they're bleeding red blood from below.
Yes, this reinforces that point we keep coming back to. A really brisk upper GI bleed can overwhelm the bowel and present as hematochezia. In an unstable patient, you absolutely have to rule out a massive UGB source first, as that might be the most life-threatening issue, before you start focusing solely on the lower GI tract.
Makes perfect sense. Rule out the fastest potential bleeder first if the patient's unstable. Okay, so if an upper source is ruled out, or if you have an LGI suspected in a more stable patient, what's the main diagnostic tool for the colon?
For most patients who are admitted with suspected LGI are stable enough and are able to undergo a bowel preparation, drinking that lovely lavage solution to clean out the colon.
Oh yeah, the fun stuff.
Then colonoscopy, after the prep, is the procedure of choice. It allows direct visualization of the entire colon lining to look for the source diverticula, ectasias, colitis, tumors, whatever it might be.
But what if the bleeding is just too heavy? Too much blood coming out too fast to even do a colonoscopy prep and get a clear view?
Good question. In that situation, where colonoscopy isn't feasible because of ongoing massive bleeding, the source recommends angiography as the next step. And it specifically notes that computed tomography angiography, or CT angiography, CTA, is often suggested prior to doing the traditional catheter angiography.
Why CTA first?
CTA is much faster and less invasive than traditional angiography. It involves injecting IV contrast dye and taking rapid CT scans. If there's active bleeding happening at that moment, the contrast will leak out of the vessel into the bowel lumen, and the CTA can show that extravasation, giving pretty good evidence that there is active bleeding in roughly where it's located. This information can then help guide the subsequent, more invasive traditional angiography procedure, making it more targeted and hopefully more successful if embolization is planned.
Okay, so CTA can help localize before the interventional procedure. The source also mentions sigmoidoscopy, just looking at the lower part.
It does mention flexible sigmoidoscopy, but primarily limits its potential use to younger patients, say under 40, who present with only minor rectal bleeding. However, there's an interesting footnote referenced in Figure 48.2 that even suggests considering a full colonoscopy for any degree of rectal bleeding in patients under 40. This might reflect increasing concerns about conditions like inflammatory bowel disease or even polyps occurring in younger individuals, suggesting a potential trend towards more complete colonic evaluation even in younger patients with bleeding.
Practice might be shifting there. Okay, what happens if the initial colonoscopy is done but it's negative? They don't find a definite source, but the patient may be bled before or is still oozing.
Right. If the source remains elusive after colonoscopy, then imaging studies may come into play. One option mentioned is a 99 milli-TC labeled red blood cell scan.
The tagged red cell scan? How does that work?
It's a nuclear medicine test. They take some of the patient's own red blood cells, tag them with a radioactive tracer, technetium 99 meter, and re-inject them. Then they use a special camera to image the patient's abdomen repeatedly over several hours, sometimes up to 24 hours. If the patient is actively bleeding during that time, even intermittently, the tagged red cells will leak out of the blood vessels at the bleeding site, and the camera can detect this accumulation of radioactivity, helping to localize the general area of the bleeding.
So it's good for intermittent bleeding.
It can be, yeah, because of the long imaging window. However, the source notes that CT angiography is increasingly being used instead of the tagged red cell scan in many centers. Why? Because CTA is likely superior in terms of spatial resolution, pinpointing the location more accurately. It's much faster, and it's generally more readily available, 247 in most hospitals. Now, in the setting of active LGB, traditional catheter angiography offers both diagnostic and therapeutic potential. It can detect the bleeding site by showing contrast dye leaking out, extravasation, and critically, it allows for immediate treatment right then and there with transcatheter arterial embolization, blocking the bleeding vessel from the inside with coils or other materials.
Okay, so angiography is key if bleeding is active and brisk. What's the last resort if bleeding continues and you can't find or treat the source with scopes or angiography?
Surgery is presented as the next step for persistent or refractory bleeding coming from the colon when the source hasn't been definitively identified or couldn't be successfully treated by those less invasive means. And the source mentions again that intraoperative endoscopy, actually performing colonoscopy or enteroscopy while the patient is in the operating room for surgery, can sometimes be used to help pinpoint the bleeding site right there on the table if it remained obscure despite all the preoperative workup. This helps the surgeon perform a more targeted, hopefully smaller surgical resection.
Okay, that covers the colon pretty well. Now, how about evaluating the small intestine specifically, or investigating that obscure jib when the initial upper scope and colonoscopy are both negative?
The approach here, according to the source, really depends on the urgency and severity of the bleeding. For patients who are having massive bleeding that's suspected to be coming from the small intestine because upper and lower scopes were negative, current guidelines cited in the source suggest angiography might be the best initial test. Why? Because of its potential for immediate therapeutic embolization if a bleeding site is found. Similar to LGIB, CT angiography or maybe a tagged red cell scan could precede the traditional angiography if the patient's clinical status allows time for it, again, to help guide the procedure.
Okay, angiography for massive suspected small bowel bleeds. What about for patients with less severe bleeding, maybe recurrent slow bleeding, or ongoing iron deficiency anemia, where the initial scopes were negative?
For those patients with less massive, or maybe more chronic or intermittent bleeding suspected from the small bowel, the source mentions a couple of initial steps might be considered. First, simply repeating the upper endoscopy and colonoscopy. Why? Because second-look procedures can sometimes find a source that was missed the first time. Maybe the prep wasn't perfect, maybe the bleeding was intermittent and wasn't active during the first scope. The source suggests these second-look scopes find a source in up to about 25% of cases. Alternatively, instead of just repeating the standard upper scope, one could do a push enteroscopy. This uses a longer endoscope, often a pediatric colonoscope, pushed down further than a standard EGD, allowing visualization of the entire duodenum and often a good portion of the proximal jejunum, extending the reach into the upper small bowel.
Okay, repeat scopes or push enteroscopy first. If those still don't find the source, how do they investigate the rest of that long small intestine?
Right, if the source remains unknown after those steps, then dedicated evaluation of the entire small intestine is the next logical step. And the source states this is usually performed nowadays with video capsule endoscopy, VCE.
The camera till.
Exactly.
Yeah.
The patient swallows a small capsule containing a tiny camera, light source, battery, and transmitter. As it travels naturally through the entire small intestine over several hours, it takes thousands of pictures, which are transmitted wirelessly to a recorder worn by the patient. Later, the doctor reviews the video footage.
How good is it at finding things?
The source cites a systematic review showing VCE has a significantly higher diagnostic yield for finding clinically significant findings compared to older methods. The numbers given were a yield of 56% for capsule endoscopy versus only 26% for push enteroscopy and 42% for small bowel barium radiography, an old X-ray technique. So it's pretty effective at visualizing the mucosa and finding lesions like vascular ectasias, ulcers, or tumors.
56% yield is pretty good, but does it have limitations?
It definitely does, and the source clearly notes them. First, the capsule doesn't always visualize the entire small intestine in every patient. Sometimes it moves too fast or too slow, or the battery dies. Second, and critically, VCE is purely diagnostic. It does not allow for taking tissue samples, biopsies, or applying any therapy, like stopping bleeding. It can find the problem, but you usually need another procedure to actually do something about it. It's a practical limitation clinicians always have to consider.
Okay, so it finds things but can't treat them. Are there alternatives to capsule as the first test for the small bowel?
Yes, the source mentions CT enterography, CTE, as an alternative initial test. This is a specialized CT scan optimized for visualizing the small bowel wall and lumen, usually after the patient drinks a special contrast agent. CTE is particularly valuable, the source notes, in patients where there's a suspicion of small bowel narrowing, maybe due to known Crohn's disease strictures, prior surgery causing adhesions, or radiation damage, because in those cases, the capsule could potentially get stuck, so CTE might be preferred first in those situations. The source also notes CTE may be used after a negative capsule study if there's still a high suspicion for a small intestinal mass or tumor, as CTE generally has higher sensitivity for detecting submucosal or extrinsic masses compared to capsule.
Got it. So let's say the capsule is positive, it finds a potential bleeding source. What happens next?
If VCE identifies a likely source, then the subsequent management is dictated by what was found. For example, if it clearly shows a tumor, that would likely lead to surgical consultation and planning. If it shows multiple vascular ectasias, the next step might be deep enteroscopy to try and treat them. If the capsule endoscopy is negative and the patient is clinically stable, the source suggests they might simply be observed and managed symptomatically, for instance, just treated with iron supplements if they have ongoing iron deficiency anemia but aren't having overt bleeds.
But what if they keep bleeding clinically, like needing more transfusions, even after a negative capsule study?
Right. If there's ongoing clinically important bleeding despite that negative initial VCE, then further investigation is definitely needed. The source suggests a second capsule endoscopy can be considered. Why? Because studies report it can identify a source in up to about 50% of cases where the first capsule study was negative or inconclusive, perhaps due to timing or incomplete visualization.
Half the time a second look finds something. Interesting. What if that's negative too, or if you need to intervene?
The next common test mentioned in the source's algorithm, especially for clinically important GIB, suspected to be from the small intestine after capsule, is deep enteroscopy. This encompasses those techniques we mentioned: double balloon, single balloon, or spiral enteroscopy. These use specialized scopes and overtubes that allow the endoscopist to methodically advance deep into the small intestine, sometimes examining the entire length from either the mouth or the anus by pleating the bowel over the scope.
And the advantage here is?
The key advantage, as the source emphasizes, is that deep enteroscopy allows not only visualization and tissue sampling, biopsies, but also therapeutic intervention. You can treat lesions found during the procedure like cauterizing vascular ectasias, clipping bleeding sites, dilating strictures, or marking tumors for surgery, thereby overcoming the main limitation of the diagnostic-only capsule endoscopy. Other imaging techniques that are sometimes used in the workup of obscure GIB, depending on the clinical scenario, include the 99 millitc labeled red blood cell scan, especially if bleeding is active and intermittent, CT angiography, traditional angiography, and specifically 99 millitc pertechnetate scintigraphy. This last one is a nuclear scan used specifically to look for ectopic gastric mucosa with endomechial diverticulum, so it's particularly relevant in younger patients with obscure GIB. And the absolute final step mentioned in the source, reserved for cases of severe recurrent or persistent obscure GIB requiring repeated transfusions when all other tests have been unrevealing, is intraoperative endoscopy. As we discussed before, this involves performing enteroscopy, or colonoscopy, while the patient is literally in the operating room, allowing the surgeon and endoscopist to work together to visually locate the bleeding source before deciding on the surgical approach, often a resection.
Wow, that is an incredibly thorough pathway for chasing down obscure bleeding. Finally, before we leave GIB, the text briefly addresses what to do about a positive fecal occult blood test, FOBT, found during screening, in the absence of any overt bleeding symptoms.
Right. The source provides important clarification here. It reiterates that FOBT, or the newer FIT tests, are recommended only as screening tools for colorectal cancer, typically starting at age 45 or 50 in average-risk adults. If one of these screening tests comes back positive, it indicates the presence of blood, even microscopic amounts, and absolutely requires a full colonoscopy to investigate the source and rule out colorectal cancer or significant precancerous polyps. But here's the crucial point relevant to our broader GIB discussion. If that colonoscopy, performed because of the positive screening test, is negative, meaning no cancer, no significant polyps, no other obvious source of bleeding found in the entire colon, the source states that no further workup is recommended specifically for a bleeding source, unless the patient also has clinical evidence of chronic blood loss, such as iron deficiency anemia, or if they develop other new gastrointestinal symptoms.
So a positive screening test plus a clear colonoscopy doesn't automatically trigger a huge workup for hidden bleeding elsewhere.
Not automatically, no, unless there are other clinical red flags like anemia or symptoms. It recognizes that minor, insignificant bleeding can sometimes cause a positive screening test, and a negative high-quality colonoscopy is generally considered sufficient evaluation in an asymptomatic, non-anemic person.
That's a really practical point for interpreting those screening results. Okay, wow. That was an incredibly deep dive into Chapter 48 on gastrointestinal bleeding. We covered everything from presentation, localization, the specific sources in every section of the gut, the detailed evaluation algorithms including risk scores and advanced imaging, right through to the specific evidence-based treatments for different conditions. It really feels like we've covered the material needed for mastery.
Absolutely. Going through Chapter 48 in this kind of detail really reveals how interconnected all the diagnostic and therapeutic steps are. You see how vital that initial clinical assessment is, how specific endoscopic findings drive therapy for ulcers, how variceal management depends on liver status, how we approach obscure bleeding systematically. It's not just about memorizing lists. It's about understanding the clinical reasoning pathway, the why behind each step, just as the professionals in the field do.
And we also managed to get that introductory glimpse into the next chapter, Chapter 49, on jaundice. The source started by defining it, that yellowish discoloration from bilirubin deposition.
Right, and emphasizing it only happens when serum bilirubin is elevated hyperbilirubinemia. Jaundice itself is just a sign pointing towards some underlying issue. Maybe liver disease, maybe a hemolytic disorder where red cells break down too fast, or maybe a specific problem with bilirubin metabolism itself.
And it mentioned how to detect it physically.
Yeah, the source notes the degree of elevation can be roughly estimated by physical exam. Slight increases are often best seen first by looking at the sclerae, the whites of the eyes, for yellowing, which is called icterus.
Why the eyes first?
Sclerae have a high affinity for bilirubin because they're rich in elastin, so they tend to pick up the yellow color even at lower levels. The source says scleral icterus usually indicates a serum bilirubin of at least 3 milligdl, or 51 mmol. It also warns that fluorescent lighting can make it harder to see and suggests looking under the tongue is another good spot. As bilirubin levels rise further, the skin turns yellow too, especially noticeable in light-skinned patients. And if it's been going on for a long time, the source notes the skin can even take on a greenish tint because the bilirubin gets oxidized to biliverdin.
Are there other things that can make your skin yellow besides jaundice from bilirubin?
Yes, and the source provides a helpful differential diagnosis for yellow skin. Besides true jaundice, it lists carotenoderma. This is a yellow-orange coloring from eating excessive amounts of carotene-rich foods like carrots or squash. The source says this is the most common mimic, but it can also be associated with conditions like diabetes, hypothyroidism, or anorexia nervosa. Certain drugs can do it too. Quinacrine was mentioned, and some newer cancer drugs like sunitinib or sorafenib, and also excessive exposure to phenols.
How do you tell carotenoderma apart from true jaundice? That seems important.
The source gives a very clear distinction. In true jaundice, the skin yellowing is usually pretty uniformly distributed over the body. In carotenoderma, the pigment tends to concentrate more on the palms of the hands, the soles of the feet, the forehead, and in the nasolabial folds around the nose and mouth. But the crucial differentiating feature is the eyes. The sclerae are spared in carotenoderma. They remain white. That's the key feature to distinguish it clinically from true jaundice.
White sclera, not jaundice. Got it. Any other signs of high bilirubin?
Yes. Another sensitive indicator mentioned is darkening of the urine. Patients often describe it as looking like tea or cola. This happens because of the renal excretion, the kidneys filtering out conjugated bilirubin.
Conjugated. Okay, that term seems important.
It is. The source emphasizes that bilirubinuria, bilirubin in the urine, specifically indicates that the direct serum bilirubin fraction is elevated. And an elevated direct bilirubin points specifically towards either liver disease or some kind of biliary tract problem like a blockage, as opposed to problems before the liver like hemolysis.
The text then starts to explain why bilirubin levels go up in the first place, getting into its production and metabolism. This is where you start to understand the different types of jaundice, right?
Exactly. This is where the aha moments often happen, understanding the underlying process. The source says simply that serum bilirubin levels increase whenever there's an imbalance between how much is being produced and how much is being cleared by the body. A logical evaluation of jaundice requires understanding this whole metabolic pathway.
So what is bilirubin fundamentally, and where does it come from?
Bilirubin is defined as a tetrapyrrole pigment. Basically, it's a breakdown product of heme. Heme is the iron-containing component of hemoglobin in red blood cells, but also other proteins. About 80-85% of the bilirubin produced each day, the source says around 4 milligrams per kilogram of body weight, comes from the normal breakdown of hemoglobin from old senescent red blood cells that are being removed from circulation. The remaining 15-20% comes from other sources, partly from prematurely destroyed red blood cell precursors in the bone marrow, ineffective erythropoiesis, and partly from the turnover of other heme-containing proteins found in tissues like myoglobin and cytochromes.
Where does this breakdown happen?
The formation occurs mainly within reticuloendothelial cells macrophages, essentially predominantly in the spleen, but also in the liver and bone marrow. The process involves two key enzymatic steps described in the source. First, an enzyme called heme oxygenase, located in the microsomes of these cells, opens up the heme ring structure. This reaction produces three things: biliverdin, which is actually green, carbon monoxide, which gets exhaled, and iron, which gets recycled. Second, another enzyme called biliverdin reductase quickly converts that green biliverdin into bilirubin, which is yellow-orange.
Okay, so heme becomes biliverdin, then bilirubin, inside these macrophage cells. The text then says this bilirubin is almost insoluble in water. Why is that?
This is due to its molecular structure. The source explains it has tight internal hydrogen bonding within the molecule. These internal bonds essentially fold the molecule up, hiding its polar, water-loving parts on the inside and exposing the hydrophobic, water-hating parts on the outside. That makes it very poorly soluble in water or blood plasma.
So how does it travel in the blood if it's not water-soluble?
It needs a carrier. To travel through the bloodstream from the spleen or marrow to the liver, this newly formed bilirubin, which is called unconjugated bilirubin, at this stage binds reversibly but tightly and non-covalently to albumin, the main protein in blood plasma. Albumin acts like a shuttle bus, making the bilirubin soluble enough for transport.
Okay, albumin carries the unconjugated bilirubin to the liver. What happens when it gets there, inside the liver cell, the hepatocyte?
Right, so the albumin-bilirubin complex reaches the liver sinusoid. The bilirubin itself dissociates from the albumin and is taken up across the hepatocyte membrane into the liver cell. The albumin stays in the blood. The source notes this uptake is partly via carrier-mediated transport, though it also says no single specific transporter protein has been definitively identified yet. Once inside the hepatocyte, this unconjugated bilirubin binds to other proteins, like those belonging to the glutathione S transferase superfamily. These intracellular proteins basically keep the bilirubin sequestered inside the cell, prevent it from leaking back out into the blood, and present it for the next critical step: conjugation.
Conjugation. This makes it water-soluble, right?
Exactly. This crucial step occurs in the endoplasmic reticulum within the hepatocyte. The liver makes the bilirubin water-soluble by attaching molecules of glucuronic acid to it. This process, called conjugation, disrupts those internal hydrogen bonds we talked about, exposing the polar groups and making the molecule hydrophilic. The specific enzyme that catalyzes this reaction is called bilirubin uridine, diphosphate glucuronyl transferase, usually just abbreviated as UDPGT or UGT1A1. This enzyme adds one or two glucuronide molecules, producing bilirubin monoglucuronide and bilirubin diglucuronide. These are the conjugated forms of bilirubin.
Okay, so now it's conjugated, water-soluble. How does it get out of the liver cell?
Yes. The now hydrophilic bilirubin conjugates diffuse from the ER to the other side of the hepatocyte, the side facing the tiny bile channels, called the canalicular membrane. From there, they are actively transported out of the hepatocyte and into the bile canaliculus. This is an energy-dependent process requiring ATP, and the source identifies the specific transporter protein involved, the multi-drug resistance-associated protein 2, or MRP2. So MRP2 pumps the conjugated bilirubin into the bile. The source adds an interesting detail. Another related transporter, MRP3, located on the other side of the hepatocyte, the side facing the blood, actually transports a portion of these conjugates back into the bloodstream, sinusoids and portal circulation. These are then normally reabsorbed by other hepatocytes via different transporters, OATP1B1 and OATP1B3. This describes a sort of intrahepatic circulation loop for bilirubin conjugates. But the majority gets pumped into the bile by MRP2. This conjugated bilirubin in the bile then drains into larger bile ducts, eventually reaching the gallbladder for storage or flowing directly into the duodenum, the first part of the small intestine. Once in the gut, the source notes, conjugated bilirubin passes unchanged through the proximal small bowel, duodenum and jejunum. Why? Because it's now water-soluble and also has a large molecular size due to the attached glucuronides, so it's not readily reabsorbed by the intestinal lining there.
And the text just stops right there. As it reaches the distal ileum and colon, kind of leaves us on a cliffhanger about what happens next in the gut. But wow, that was a truly deep dive, wasn't it? We really unpacked that source material. We covered the different ways GIB can show up, overt versus occult. We went through the specific sources, ulcers, varices, tears, erosions, vascular stuff, tumors in the upper tract, the small bowel, and the colon. We detailed the evaluation steps, the vital signs, the hemoglobin lag, the risk scores like Glasgow-Blatchford, the role of NG tubes, the timing of endoscopy, the use of imaging like CTA and capsule, and the specific treatments, from endoscopic therapies like clipping and banding, to medications like PPIs and octreotide, to interventions like TIPS and embolization, and even when surgery is needed. Plus, that fascinating intro to bilirubin metabolism and jaundice, it feels like we really extracted the core knowledge needed for mastery.
Absolutely. We looked at prevalence, costs, mortality figures, the diagnostic yield of different tests, how therapies compare based on trials like the PPI dosing or the transfusion threshold, and even those specific evidence-based recommendations like restarting aspirin for secondary prevention or using early TIPS and high-risk cirrhotics. It really gives you a detailed picture, doesn't it? Helping you understand not just the what, but the why behind diagnosing and managing these conditions, really getting into the clinical reasoning just as the experts in the field would approach it based on this kind of source material.
It's like getting that shortcut to being really well-informed without having to wade through the dense primary texts yourself. After going through all this detail, what particular insight or theme stands out most to you?
For me, I think it's two things. First, just how rapidly our understanding and especially our diagnostic tools evolve. Thinking about how things like capsule endoscopy and CT angiography have completely changed how we approach obscure GIB compared to maybe 20 years ago. And second, how really specific detailed clinical trial results like the transfusion threshold trial or the aspirin restart trial or the early TIPS trials directly translate into very concrete changes in patient management recommendations. It underscores how dynamic and evidence-driven this field is.
That definitely comes through. And it raises an important question, doesn't it? Given how technology and research constantly refine our understanding, like we just saw with GIB management, and started to see with bilirubin pathways what might be the next major leap. Could it be something related to personalized medicine based on genetics influencing bleeding risk or drug metabolism? Maybe advanced AI analyzing endoscopic images? Or perhaps something stemming from a deeper understanding of those bilirubin metabolic pathways we just scratched the surface of, leading to new therapies for liver disease or jaundice? That's certainly something for you, the listener, to mull over.
Well, thank you for bringing this fascinating and incredibly detailed source material to us for this deep dive. We hope exploring it together has helped build that professional level understanding. If you have a topic you want us to explore with this kind of depth, definitely send us your sources.
Indeed. Until the next deep dive.